Okay, welcome to the session, friends. So we'll complete it as fast as we can. Okay. So I think we were wait. Okay. So we finished up to inotropic effect, right? Inotropic effect of heart. Now we'll discuss something. We'll continue with the inotropic effect of heart, right? Inotropic effect of heart. Now, beta 1 sympathetic stimulation causes increased heart rate. It is a chronotropic condition. Chronotropic means there is a increase in heart rate, increase stroke volume, that is there will be a positive increased stroke volume present, and it is positive inotropic, and there is increased conduction, there is positive dromotropic, then there will be increased excitability, that is positive bathmotropic, okay. So these are the effects of beta 1 sympathetic stimulation, right? Now what are the factors affecting the venous return? This is very important. What are the factors affecting the venous return? Okay, now we will discuss something. The first one is gravity or posture. Why? So maximum venous return is seen in supine position. Maximum venous return is observed in supine position. Number 2 is the muscle pump. What is that muscle pump? Present at calf muscle, like soleus, right? So the venous return increases during walking, and also during exercise. So that's why daily 40 minutes of exercise is the minimum schedule for any normal well-being person. For example, if you are suffering with a cardiac issue, if you are suffering with some sort of a health issue, you suggest your doctor and get to know, but at least remember daily morning a 20 to 40 minute exercise session is very important for good heart health. This is the reason, right? Because it increases the venous return. If there is an increase in return, then obviously there will be an increase in end diastolic volume, and the ventricles activity increases, so the heart goes on strongly, right? Now the third condition is the venous valves. Why? Because these valves prevent the backflow. Once it flows towards the forward side, towards the heart, towards the cardiac region, it prevents the backflow, right? It's as simple as like that. Now inspiration is also important because there is a negative ITP. The negative ITP will pull the blood towards heart, right? Pull the blood towards because the negative ITP will pull the blood towards the heart. Now sympathetic nerve stimulation, that is alpha 1, which leads to venoconstriction and increased venous return. So sympathetic nerve stimulation, that is alpha 1 receptor, which leads to increase in venous return due to venoconstriction, right? Now it also depends on the deep fascia. How? Because thick and tight in legs keep muscles and veins compressed, thereby increase. See, thick and tightness in the legs keep muscles and veins compressed, thereby increasing venous return. Okay. We will discuss some different types of vessels. Okay, now the first one is Win Kessel vessel. Win Kessel vessel, these are large elastic type of arteries like aorta. Okay, they stretch in systole, they stretch in systole during systole and recoil during diastole, Now this feature is the important condition which causes a little bit pressure during the diastolic phase of aorta as well as the pulmonary trunk. See, previously in the previous session we heard aorta, even in diastolic phase also you have some pressure. I think it is 25 or like, right? Even in the diastolic condition also aorta has 80 mm Hg of pressure and pulmonary artery has 10 mm Hg of pressure. Why? This is the reason, because large elastic arteries, they stretch during the systole and they recoil during the diastole. This recoiling condition gives the pressure during the diastole also. Okay, now you got to understand previously why we discussed that statement. This is the reason. Okay, so these vessels are large vessels called Win Kessel vessel, right? Win Kessel vessel. So they recoil inwards towards the diastole. Now this compressed blood, right? This compressed blood to produce diastolic blood pressure. See, during the diastole, see, for example, this is the vessel. So during the systole, what happens? During the systole, right, these vessels, they stretch during the systole. Why? Because the blood moves with more pressure, right? So they stretch. So during the diastole, what happened? This already stretched vessel, what it happens is it relaxes or comes to a relaxed state, but with a little bit of recoil. That recoil happens inwards because previously due to systole it has been stretched. So now during the diastole, what happens is there is a recoil towards the inward. So while it is going into the recoil towards the inward, it applies some pressure on the blood column. So it applies some pressure on the blood column. So obviously this leads to produce some diastolic blood pressure, right? Diastolic blood pressure. So the diastolic blood pressure in aorta is 80 mm Hg. Previously we will discuss it, right? So this 80 mm Hg is produced due to this diastolic condition, recoil of the aorta, right? And it maintains the blood flow in the diastole. This helps in maintaining the blood flow in the diastole. Now coming to the second type of vessel, called capacitance vessels. Capacitance vessels. These are actually systemic veins. Actually they have high compliance. Compliance means stretching, the capacity of stretching, high compliance, right? They stretch and they store the blood. Due to their high compliance, they can stretch to a higher capacity and they can store blood. Almost like they contain 50 to 60% of the storage blood. Remember. So obviously by storing lots and lots of amount of blood, it helps in compensating the blood loss during emergency condition. So that's why these vessels are defined as capacitance vessels. They have the capacity to store lot of blood, nearly 50 to 60% of the storage blood. Now the third type of vessels are exchange vessels. Now exchange vessels, you can easily guess. What are examples for exchange vessels? Capillaries. Capillaries, right? Capillaries are the examples for exchange vessels. For example, right, you take it, they have a feature of permeability and they are lined with simple squamous endothelial cells, right? Simple squamous endothelial cells. Now they have a minimum blood volume, something like 5% of the blood, 5% of the blood. And remember, they have the slowest speed, but they have good exchange capacity, as well as silent laminar flow is observed in the blood flow. Silent laminar flow is observed in the blood flow in those capillaries. Now one more important thing is they have low pressure. Why? Because they move very slowly, they have slowest speed, they have low pressure. So if there is low pressure, what will be low? Proportionally, obviously resistance will also be low only. So in the capillaries there will be low resistance due to low pressure. And one more important thing is, please don't forget this line. These vessels, they have, I will write with red color, maximum cross section area. Maximum cross sectional area. Why? Because there are billions on billions of capillaries. There are billions and billions of capillaries, and hence they are all arranged in a parallel manner. And remember one thing, if you take arteries, for example, where's the pointer? Yeah, if you take, here's the pointer, man. Yeah, here it is. I can't see the pointer itself. Okay, if you take arteries itself, they have the maximum speed, as well as turbulent flow. So it is due to turbulence flow, it produces some noisy condition. Okay, they have turbulent flow and it is noisy. Okay, so that's it. That's all about exchange vessels. Now coming to the final type of vessels, that is the resistant vessels. What about the resistant vessels? What is the time? It's 2. Resistance vessels, right? These are nothing but muscular arteries and arterioles. Okay, and also they include the smooth muscles, help in contract and relax. Right? These smooth muscles, they contract and relax, and obviously they change the diameter. These resistance vessels, they change the diameter which control the blood flow. You understand or not? Say one thing. See, the resistance vessels are nothing but the muscular arteries and their arterioles. So these are generally seen in the conditions like smooth muscles which contract and relax themselves. And these resistance vessels, they change the diameter, which obviously controls the blood flow, thereby controlling the blood flow. Right now, arterioles, these are actually the main resistance vessel. Right? They have a sympathetic supply and maximum in smooth muscles. Smooth muscles, right? Now if you ask me what is their control regarding with which receptors they have been controlled, you take alpha 1, beta 2. Alpha 1 initiation causes vasoconstriction, right, that leading to decrease in blood flow. Now present everywhere in skin, GIT, then kidney, muscle, etc. Now we come to beta 2. Beta 2 activation leads to vasodilation, thereby increasing the blood flow, and these are present only in few sites, something like mainly muscles, sweat glands, uterus, etc. Okay. Now these arterioles, they cause or offer resistance at the tissue level, right? At the tissue level only. Remember, at the tissue level. But the main site of peripheral resistance, right? The main site of peripheral resistance, remember I write here, the main site of increased peripheral resistance will increase load on ventricle after they start contraction, right? So the main site of increased peripheral resistance will increase the load on ventricles after they start the contraction. Now this condition is called afterload. You got it or not? Okay, understood? So what is preload? Previously we discussed. I will write here what is preload. Here you got about afterload. Then what is preload? If there is an increased end diastolic volume, what it happens? If there is increased end diastolic volume, it obviously increases the stroke volume. That increased stroke volume, this condition phenomenon is called a preload. Right? What happened actually? So there will be an increased diastolic and there will be an increased end diastolic volume. So that leads to, wait, I will write here again. Someone is asking about preload. See, preload is simple. If there is an increased end diastolic volume, it leads to filling of ventricles, right? During the filling of ventricles, the ventricles are filled more than the normal volume because there is an increased end diastolic volume. So the ventricles will be filled more than the normal volume. So even before the reaching the contract state or the systolic state, the ventricle itself are increased with some pressure. So this increase in pressure due to the increased end diastolic volume, this phenomenon is called a preload. Right? Means just as in the dilated ventricles, the ventricles did not even start the systole, but still as the dilated ventricles are accepting the blood from the atria, as the end diastolic volume increased, means the volume of blood, the amount of blood during the diastole is increased, thereby leading to increase in pressure of the ventricles. This condition is called as preload. Right? Now coming to the blood flow regulation, very important topic. Okay, what is that? blood, no, this is worst, this is not nice. I'll write here blood flow regulation. Okay, blood flow regulation. Flow is equal to pressure by resistance. Flow is equal to pressure by resistance. Okay, F is equal to P by R. See, remember these formulas, it will be helpful in the examination. Flow is equal to pressure divided by resistance. Now see, simply I can denote one thing: organs can control their blood flow, organs can control their own blood flow just by changing the resistance, Now this phenomenon is called, what is that? Autoregulation. This phenomenon is called autoregulation of flow. For example, I will tell you with an example. For example, if there is an increased flow to muscle, right? If there is an increased flow to muscle, there will be a increased pressure by sympathetic activity. Increased pressure by increasing the sympathetic activity. You understood? Or not? It's simple. In exercise, what happens? For example, if you are doing an exercise, obviously the muscle which is being utilized in the exercise, to that muscle the blood flow will be increased. So obviously what the body will do? The body will simply increase the blood pressure by increasing the sympathetic activity. That's it. It's called as autoregulation. It's as simple as like that. So due to exercise, the blood flow to the muscle increases, and to compensate it, the blood pressure is also increased. How? By increasing or stimulating the sympathetic activity. Now there are some components like lactic acid, or you say increase in partial pressure of oxygen. These are the conditions: lactic acid, increase in partial pressure of oxygen, increase in partial pressure of carbon dioxide, or adenosine, proton, increase in temperature, etc. They obviously cause dilation. Which dilation? Vasodilation. These conditions cause lactic acid or increased partial pressure of oxygen, increased carbon dioxide concentration, increased temperature. These all conditions cause vasodilation. That means it leads to decrease in resistance and increase flow, right? Now this type of phenomenon is called metabolic autoregulation. Now you might ask me, why metabolics are? Because here you're using metabolic oriented reactionary components. See, these all components deal with metabolism. You take lactic acid, oxygen partial pressure, carbon dioxide partial pressure, temperature, then you take histamine, you take proton. See, these all are the components of metabolism, right? These all are the components of metabolism. So if these metabolic components, if they get increased, obviously it causes vasodilation. So when the vasodilation occurs, obviously it leads to decrease in resistance and increase in flow. This type of regulation is called as metabolic autoregulation. And trust me, this metabolic autoregulation is the best regulation of blood flow, or best autoregulation in heart and brain. So our body compensates the blood flow in different maneuvers. You can't even imagine, right? In different maneuvers. Now I will tell you a simple equation for the resistance, blood flow, the length, the radius, how it is calculated. You take resistance as R, it is 8 times, right? It is 8 times the viscosity, that is provided by mu n, to the length divided by pi r to the power, sorry, I should write it small r to the power of 4. R is, see, n is viscosity value of blood, L is length of the blood vessel, L is length of the vessel length, of the vessel, and R is the radius of the vessel. Pi value everybody know, 22 by 7, that is 3.143 something, right? So you can get the resistance offered in a vessel by doing this calculation. So always remember one equation for sure: resistance is inversely proportional to radius with 4 times the factor. That implies if the radius is increased, the resistance gets decreased. If the radius of the vessel is increased, the resistance gets decreased. But if the radius of the vessel is decreased, the resistance gets increased. You got it? You got my point or not? Okay. Now some of the people may also say like this: if you double the radius, right, then your resistance will decrease by 2 to the power 4 times. That means how much? Your resistance will decrease by 16 times. Got it or not? Please say you got it or not. See, there is no much confusion, guys. Resistance is equal to 8NL by pi r to the power of 4. This is the formula for calculating the resistance in a vessel, guys. This N is viscosity of the vessel, then L is length of the vessel, pi is pi value 22 by 7, R is the radius of the vessel, and R is the resistance. So leave all these factors, but you only take radius of the vessel, you only consider. So the resistance offered by a vessel is inversely proportional to the radius to the power of 4 times. For example, if the resistance is increased 1 time, the radius gets decreased by 4 times. The radius of the vessel gets decreased by 4 times, right? To increase the resistance by 1 time, the radius of the vessel should be decreased by 4 times. Wait 1 minute. Okay, so with this we finish the calculation part. Now we will coming to the blood pressure. Coming to the blood pressure. How will you calculate the blood pressure? Blood pressure is calculated by cardiac output into pulse rate. Okay, now if you come to the systolic blood pressure, then obviously it is 120 mmHg is the systolic blood pressure. Now why this systolic blood pressure is produced? This you should know. It is due to ventricular contraction. Ventricular contraction. And it mainly depends on the cardiac output. Mainly depends on the cardiac output. Now if you come to the second blood pressure, that is diastolic blood pressure, how much it is? 80 mmHg. Right? Now why it is produced? Why diastolic blood pressure is produced? It is due to recoil, elastic recoil, and elastic recoil of what? Anyone? Elastic recoil of the ventricle or the arteries? Anyone? Ventricles only. Ventricles only. Elastic recoil of the ventricles only. And it depends mainly on the pulse rate. Remember, and it depends mainly on the pulse rate. See, systole depends on the cardiac output and diastole depends on the pulse rate mainly. Okay. Now another pressure is pulse pressure. Another pressure is pulse pressure. Pulse pressure. Now when coming to the pulse pressure, it is the difference of systolic blood pressure minus diastolic blood pressure. This is the pulse pressure. Now what it indicates? It indicates the blood flow. It indicates the blood flow and it indicates the arterial compliance. That means the arterial stretchability or compliance. So arterial stretchability or compliance. Okay. Now what about mean blood pressure or mean arterial pressure? Mean blood pressure or mean arterial pressure. It is from 95 to 100 mmHg. 95 to 100 mmHg. Now the mean blood pressure is something like 2/3 of diastolic blood pressure. 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure. Now this gives the mean blood pressure. This gives the mean blood pressure. Okay, mean blood pressure can be calculated by 2/3 diastolic blood pressure plus 1/3 systolic blood pressure, or you can also calculate it like diastolic blood pressure plus 1/3 pulse pressure. You can also calculate like, or 2/3, sorry, you can also calculate with diastolic blood pressure plus 1/3 pulse pressure. Okay, clear or not? Clear or not? Please tell. Clear or not? Clear or not? Okay. Okay, now we will discuss something about cardiovascular regulators. Cardiovascular regulators in medulla. What are the cardiovascular regulatory centers in medulla? Okay. Now the first one is VMC, vasomotor center. Vasomotor center. Where it is located? It is located. See, listen carefully. It is located in rostroventrolateral medulla. RVLM. Rostroventrolateral medulla. Rostroventrolateral medulla. What it does is it increases the sympathetic activity, leading to increase in systolic volume, increase in heart rate, and increase in BPC, etc. Other changes also it will cause, but mainly these three changes. That is about vasomotor center. Now if coming to cardiovagal center, it is actually a vagal nuclei. It's actually a vagal nuclei which is present in NTS and NA. Right? What it does is, NTS means nucleus tractus solitarius, man. Why you want to confuse it? Nucleus tractus solitarius. Okay. Now what it does is it increases parasympathetic activity by vagus nerve stimulation. By vagus nerve stimulation. Now what it does is it simply activates the acetylcholine action of M2 receptor. leading to decrease in all effects of parasympathetic activation. You know now, you studied in pharmacology. Of course you are studying physiology, but you are not first year now. You already finished pharmacology, you finished all the final year subjects, everything. So obviously acetylcholine activation, M2 activation means what? You know everything, right? You know about what happens if the parasympathetic activity is activated. You know, heart rate decreases, cardiac output decreases, blood pressure decreases, secretions increases, all these things, all regarding cardiovascular actions. You write simple, that's it. Okay. Now we will discuss something about baroreceptors. Okay. Now what does this baroreceptors do? You already know that it controls the BP. But what actually these are the stretch receptors where arteries, stretch receptors and arteries. Now what they do is they mainly sense and regulate the mean blood pressure. They mainly sense and regulate the mean blood pressure at a range of 60 to 80 mmHg. Now how do they act? They act by negative feedback. Remember, baroreceptors act by negative feedback. Already we discussed in the initial chapters of physiology. I no need to discuss. And always what they do is they decrease the BP, decrease the heart rate by inhibiting the vasomotor center as well as initiating or stimulating the cardiovagal center. What happens if the cardiovagal center is stimulated? Previously we discussed. They initiate the cardiovagal center. What it will do? It will initiate the parasympathetic system. What is parasympathetic system will do? It initiate the acetylcholine oriented stimulation by M2 receptors, causing decrease in heart rate, decrease in BP and all other things. Okay or not? Okay. Now what happens if you destroy baroreceptors? If you destroy baroreceptors, what will happen? Simple, BP will increase. Right? Why? Because the vasomotor center becomes uncontrolled. Right? So it leads to what condition? Neurogenic hypertension. You got it? Now where is the baroreceptors located? They are located in the where? Same as peripheral chemoreceptors. Nothing much special, but they are located same as peripheral chemoreceptors. Okay. Now what? Same as peripheral chemoreceptors. Yes, man. Yes, same. See, they are located in the aortic sinus. Even this one we already discussed, na? Aortic sinus and the carotid sinus. We already discussed, man. Aortic sinus and carotid sinus. Aortic sinus. Yes, aortic sinus and carotid sinus, controlled by 10th nerve and controlled by 9th nerve. Simple. That's it. So there are two groups of two groups of baroreceptors. One is aortic sinus baroreceptors, I will write here, and another one is carotid sinus baroreceptors. Aortic sinus baroreceptors controlled by 10th nerve, and carotid sinus baroreceptors controlled by 9th nerve. Okay, happy, enjoyed. Okay, now we will discuss something about the CVS reflexes, guys. We should finish physiology today, but you are still lagging, right? The first one is Bainbridge reflex. Bainbridge reflex. What is a Bainbridge reflex? It is actually a compensatory reflex. Remember always, it is actually a compensatory reflex resulting in, or it causes increase in heart rate. Simply write heart rate right? What happens following a cardiac preload? Cardiac preload, generally seen in IV fluid therapy. For example, if you give IV fluids to a patient, right, what happens is it causes a changes in cardiac preload. This change in cardiac preload, this causes an initiation of a compensatory reflex called Bainbridge reflex, by which it increases the heart rate. Okay, so that is the reason why we give IV fluids to a patient whose heart rate is very low. We give the IV fluids so that it increases the heart rate by a compensatory reflex. Okay, now one more reflex is Bajol-Jaris reflex. Bajol-Jaris reflex. What this reflex is? This reflex is actually a triad of responses. This reflex is actually a triad of responses. What is the triad? First one is apnea. Second one is bradycardia. And finally the third one is hypotension. So this triad of responses are seen in the Bajol BJ reflex after giving an IV injection of capsaicin or veratridine or 5-HT, 5-hydroxytryptamine, etc. If you give any of this injection, either capsaicin or veratridine or 5-HT, etc., they cause these three triad of responses: apnea, bradycardia and hypotension. That is called Beecher reflex. And the final one is called Mary's law. What is Mary's law, guys? This is very important for NEET PGTs. Okay, what is Mary's law? Mary's law states that BP is directly inversely proportional to heart rate. BP is inversely proportional to heart rate. How? For example, you take the condition of shock. In shock, what happened? The blood pressure decreases, but there is an increase in heart rate, right? How the heart rate increases? Due to stimulation of sympathetic nervous system. Now this condition is called as, what is this condition called? Reflex tachycardia. This is called reflex tachycardia, remember. So reflex tachycardia is observed in Mary's law. Is a result of Mary's law. That means blood pressure is inversely proportional to the heart rate. Now the second thing you see is in Mary's law regarding Cushing's reflex also. Cushing's reflex also follows the Mary's law. How it follows? If there is any head injury, it leads to increase in intracranial tension. Now this intracranial tension, it might cause increase in blood pressure, but the heart rate gets decreased. So in head injury, there will be increase in intracranial tension, which leads to increase in blood pressure, but the heart rate will decrease. Now how the heart rate in this condition will decrease? This is due to action of what? Baroreceptors. Yes, baroreceptors. Right? Now this condition is called, this decrease in heart rate by the baroreceptors when there is an increase in intracranial tension leading to increase in BP. This whole phenomenon is called reflex bradycardia, seen in Cushing's reflex. Now you understand, right? You understand or not, everyone? Okay guys, with this we finished CVS, we finished RS, we finished general, right? We finished GIT. Then what? I think we are completing we are just making of all important things. Okay, now there are two more important systems, that is renal system and the CNS or neural system. Okay, now we will start something about renal physiology or renal system, renal physiology. Okay, right. Now I will draw a burst diagram. Please don't get scared. This is Bowman's capsule. No, wait. I will draw it different color. Okay. Okay. This is Bowman's capsule. Okay. This is proximal convoluted tubule. This is loop of Henle. This is distal convoluted tubule. Obviously you have collecting duct or collecting tubule. Okay, now you have something called glomeruli, right? Now this is efferent. This is afferent. This is glomeruli. See, this is all like teaching LKG classes to students, but still you listen once, right? There is no wrong in reading all these things once again, right? Bowman's caps. This is PCT, this is loop of Henle, this is DCT, and this is what is that? Which tubule? Collecting tubule. Sorry, this is collecting tubule. Okay or not? Yes. Sorry. I wrote it in reverse. I just wrote it down in reverse. Sorry. Now this is afferent. This is afferent. Taking from the body and filtering it and giving off. Okay, if afferent. Now afferent is wide. I will tell you why this is wide and efferent is narrow. Why this is wide and why this is narrow, I will tell afterwards, right? So okay or not? Yes. Now we will discuss here this efferent vessel which is going like this. Actually what it does is it forms a capillary network. What is that capillary network? Forms a capillary network. Right? Now we will just draw a simple line. Right? We will draw a simple line. Now this region is cortex, so it resides in the cortex, and this region resides in the medulla. Okay, this is cortex and this is medulla. You heard it? Is in it? I will be marker. So this is cortex, right? This all portion is cortex, and these all portion is medulla. Okay, understood. Okay, now I think we will just keep this diagram like this and we will write it in a fresh page. So the first one is glomerular capillaries, GC. glomerular capillaries, what they do is they filter plasma. They filter plasma mainly by size of the molecule. They filter plasma mainly by size of the molecule. Now after filtration, these substances which are filtered, they enter into tubules. Right? Now what are the things that get reabsorbed and what are the things that are secreted? This is very important. Now all the good solutes, what are those good solutes? You take it like glucose, amino acids, water, sodium, etc. These all will get reabsorbed. And also what happens is they enter the blood, they get reabsorbed and they enter the blood. How? Through the peritubular capillary network. Through peritubular capillary network they enter the blood from urine itself. Urine means from which portions? From tubules. See, simple guys, that's why I kept the diagram. See, you know this red thing we are seeing, this red color line, this is all peritubular capillary network. Peritubular means surrounding outside or around the tubules, right? So peritubular capillary network. Peritubular capillary network. Now the urine which is going through these tubules, this proximal canal tubule, distal canal, loop of Henle, distal canal tubule, when the urine is flowing in these tubules, the solutes or the important substances which are good, they actually get reabsorbed into this peritubular capillary network and enter into the blood present in this capillary network. In that way the substances are reabsorbed. Okay. Now what are the things that are secreted? Now this is also important. Uric acid, bad substances like uric acid, and solutes like drugs, toxins, everything, metabolites, urea, all are removed from the blood to urine tubules. See, now this is what you should observe. This red color is peritubular capillary network. I write here. Red color is peritubular capillary network. See, one thing you should understand clearly. Most of the doctors, they get confused. And this blue color is, what is that? Tubular structure, or it is nephron. So you have different tubules: proximal tubule, distal tubule, collecting tubule, then loop of Henle, but still we will call them as tubular network or also nephron, right? Now regarding reabsorption takes place from tubules to peritubular capillary. Reabsorption takes place from tubules, from urine present in the tubules to peritubular capillary network. The good substances are reabsorbed, whereas the secretion takes place from peritubular capillary network to into the urine present in the tubules of nephron. Secretion. Right or wrong? Right. Now, what are the steps of urine formation and plasma clearance? What are the steps of urine formation and plasma clearance? Right. Now the first step is filtration. Second step is reabsorption. Third step is secretion. Now glomerular filtration. Now we'll discuss something about glomerular filtration membrane. glomerular filtration membrane. So actually it is a 3-layered membrane. It is a 3-layered membrane. So what are actually participating in it? Endothelial cells of glomerular capillary. It is the opening between cells, right? It's an opening between the cells and our fenestration ranging from 70 to 90 nanometers. And also the basement membrane which contain negatively charged sialoproteins and heparin sulfate. Now what they do is, these sialoproteins, they repel and the basement membrane, they repel and prevent filtration of negatively charged plasma proteins. Filtration of negatively charged plasma proteins. Now another component which makes the glomerular filtration membrane is epithelial cells of BC, Bowman's capsule. Epithelial cells of Bowman's capsule. So what are these? They form a foot-like process. Which defines them as podocytes with a filtration slit of 10 to 20 nanometers. Now the net pore size is something like 4 to 8 nanometers. Now substances which are less than 4 nanometers are freely filtered. Substances which are less than 4 nanometer size are freely filtered, like inulin, glucose, sodium, right? Now substances which are greater than 8 nanometers, right, are not filtered. Filtered means excreted. Don't think like others. Filtered means excreted. So substances which are more than 8 nanometers of size are not filtered. So what are those substances? Example, you take RBC, WBC, all these cells, WBC, then you can take like platelets also. Yes, platelets also, even some macroglobulins, something like beta macroglobulins, then myoglobins, and something like these all are not filtered. That's why when we do urine micro examination, we check for RBCs or pus cells nothing but WBC cells, white blood cells, right? Sometimes we see for RBCs or CAS, blood, anything. So that is the reason why, because RBCs will not be seen in urine. Why? Because the RBCs are more than 8 nanometers in size, so they cannot be filtered. Easily. So obviously RBC will be in the column, blood column only, in the vessels only. But if the RBCs are seen in the urine, when you just went to the washroom, if you see RBCs in the urine or blood in the urine, that implies there is a serious problem with your kidney. So that's why we check for any RBC cause in renal function tests, or in urine microscopy we check for if there is any RBC cells or RBC cats. Okay. What is the diameter of a RBC? 7.2. Radius 3 plus. Okay. So I think we got up to here. Now myoglobins are actually not filtered. Myoglobins are not filtered. What is meant by myoglobin? Hemoglobin present in the muscle component is called myoglobin. So myoglobins are actually not filtered, and it is bound to plasma proteins. Actually, that is the main reason. It's bound to plasma proteins. And one more thing is, hemoglobin actually bind to haptoglobin, so it's not filtered. And if the size depends between, so we discussed about less than 4, more than 8, but we did not discuss in between 4 and 8. For example, if the size is between 4 and 8 nanometers, then what will the substance go? What will the substance will take a change? For example, will the substance be filtered or will it not be filtered? Now if the substance size is, or the molecule size is between 4 to 8 nanometers, then it depends on the charge whether it gets filtered or not. The condition depends on the charge of the molecule or substance. Charge of the molecule or the substance. For example, I will tell you one example. You take albumin. What is the size of albumin? 7 nanometers, right? So albumin can be filtered by size, because less than 8 nanometers anything can be filtered. So according to size it can be filtered. But remember one thing, due to the presence of negative charge on the albumin, this negative charge makes it cannot be filtered. Cannot be filtered. Due to this negative charge, it makes albumin unfit for filtration. Okay. Now this principle, this negative charge present on the albumin, now this is the principle which occurs during nephrotic syndrome. See the clinical aspects, how it was linked in nephrotic syndrome. In nephrotic syndrome, the negative charge of albumin is lost. This leads to albuminuria, means even the albumin also filtered. Why? Because the charge on the albumin is lost, because that is the charge which keeps it unfiltered. But when the charge is lost, it becomes filterable. Right? Now we will discuss something about PCT, proximal convoluted tubule. Remember nicely, guys. PCT. Now this PCT has the max out ATP, then oxygen, blood flow, all these things. Why? Because it shows the maximum amount of secretion. Maximum secretion is done by PCT, and reabsorption also occur in PCT. Now all the substances maximum reabsorption occurs in PCT. All the substances maximum reabsorption occurs in PCT, except one thing, that is magnesium. The reabsorption of magnesium occurs in ascending loop. The reabsorption of magnesium occurs in ascending loop. Now all the substances, the maximum secretion occurs in PCT, except potassium. Where does the potassium excrete? It excretes in the P cell. Except potassium present in P cell, and as well as urea is also excreted in thin loop of Henle, not in PCT. Remember, rest of all the substances, the maximum secretion occurs in PCT except potassium in P cell and urea in thin loop of Henle. And seed, wait 1 minute. Okay, and potassium in P cell and the urea in thin loop, right? Now maximum acid secretion is seen in PCT. Max acid secretion is seen in PCT. Now maximum buffers in PCT control pH of the body. Now main buffer present in the PCT, that is bicarbonate. They need carbonic anhydrase inhibitors. Carbonic anhydrase enzyme. They need carbonic anhydrase enzyme. Okay, what is the main buffer in PCT? That's bicarbonate. Why? Because they need carbonic anhydrase enzyme. Now what are the minor buffers in PCT? What are the minor buffers in PCT? That is ammonia and phosphate. Okay, and that is all about PCT. Now coming to loop of Henle. Just 1 minute. Okay guys, I think we are back. Sorry, this is slight disturbances in the system itself. There's a slight problem. There's a slight disturbance. Okay, no problem. Now it's cleared. There is a slight disturbance in the system itself. No problem. It's clear. So okay, now discussing about the loop of Henle, right? So the medulla has more osmolarity. Remember, the medulla means which medulla? Medulla of the kidney. The medullary portion of the kidney has more osmolarity. If you ever studied, it has more osmolarity, something like 1200 milliosmoles per liter. So 1200 milliosmoles per liter. Now that is something like 4 times the plasma osmolarity. 4 times the plasma osmolarity. How much the plasma osmolarity is? 300 milliosmoles per liter. Now that is why it is called as a hypertonic solution. So the solution that is passing through the medullary portion of kidney, that is in the loop of Henle, is defined as hypertonic, because this osmolarity is 1200 milliosmoles per liter. That is too much. Now the medulla, what the medullary portion of kidney will do is, the medulla will pull the water. The medulla will pull the water that is present in the urine. Okay, and what it does is, it makes a concentrated hypertonic urine. Up to how much concentration does it take? It takes the concentration of urine up to 1200 milliosmoles. That too much concentration. That is too much concentration, right? In which part the 1200 milliosmoles osmolarity will be present? It is present in the descending part of the loop of Henle. And also in the where in which part you will see this much of osmolarity again? Collecting duct. Why in collecting duct? Because that is why we need something called antidiuretic hormone, right? That is why we need something called antidiuretic hormone, right? Why antidiuretic hormone? Can anyone? Because if the diuresis occurs, it needs more concentration. It will become more concentration. So that's why we need antidiuretic hormone. Now, if longer the loop, more concentration power. Now this is what is called as juxtamedullary nephrons. Now the descending loop, you take it, the descending loop is actually water permeable. So obviously it forms a hypertonic urine, because the water is permeable, the water gets reabsorbed. So if the water gets reabsorbed from the urine, the descending loop which is receiving the urine, obviously it receives a hypertonic urine. The descending loop is a water permeable component, right? Now if you take the ascending loop, after the descending loop, what will continue? It will continue as ascending loop, which is solute permeable, which this leads to hypotonic urine. If you understand or not, see, I will explain even better. This is now this is loop of Henle, right? This is descending loop. Rest of all is ascending loop. For example, just I will make it with different color. This is ascending loop. Now this one is descending loop. So what happens is, as the urine flows down all along the descending loop, the osmolarity increases. the osmolarity increases. So obviously the descending loop has hypertonic urine, and one more thing is the descending loop is permeable for water. So this permeability or the reabsorption of water leads to formation of hypertonic urine, but the ascending loop is permeable for solutes. Now this reabsorption of solutes leads to formation of hypotonic urine. Now you understand why? Because tomorrow in NEET PG you will get a question like hypotonicity of the urine in the ascending limb is due to increased permeability to water or increased permeable to solutes. It's increased permeable to solutes. That's why as the solutes are reabsorbed from the ascending limb to the blood, so obviously the urine in the ascending limb will become slowly hypotonic because it is losing the solutes. If it is losing the solutes, the concentration decrease or increase? It will decreases. If the concentration decreases, the tonicity increase or decrease? It decreases. So hypotonic. You understand or not? Did you understand or not? Please. Yes. Now you will just take into another important topic, counter current system, that is CC, that is counter current system. Okay, now what is counter current system? It is something which increases the concentration of urine, the system which increases the concentration of urine. So you have two things, counter current exchanger and counter current multiplier. Counter current exchanger and counter current multiplier. So what happens in counter current exchanger? In counter current exchanger there is ascending loop. It is present in the ascending loop. Counter current I'll clear it off. Counter current exchanger and counter current multiplier. So counter current exchanger is present in vasa recta. Okay, it is present in vasa recta, right? And counter current multiplier is present in ascending loop. So what counter current exchanger do? Counter current exchanger, it maintains the medullary osmolarity. By water reabsorption. Whereas counter current multiplier, it simply creates high medullary osmolarity, that is up to 1200 milliosmoles per liter by accumulating solutes. Okay, by accumulating solutes. Now we will just look into some mechanisms. Okay, we'll just look into some mechanisms. Just 1 minute. So what happens is, if you take something like ascending loop, right? Thick ascending loop. Just 1 minute. Yes. So what happens actually? So back to the point. In case of ascending loop, that is the counter current multiplier, what actually happens? Wait. I think we'll do it in a another page. We'll just write it here. In case of a counter current multiplier is present where? Counter current multiplier is present in ascending loop. Now what happens in ascending loop? You take an ascending loop, what it does is, it simply, in case of a thin ascending loop, so you have two segments in ascending loop, one is thin, another one is thick. Thin ascending loop, what it does is, it helps in transport of sodium and chloride, transport in the medulla. Now thick ascending loop, what it does is, it simply helps in the transport of sodium, potassium, chloride, co-transport due to presence of co-transport. Simply transport these ions, sodium, potassium, chloride, and when it's coming to the medulla, potassium chloride, it becomes hyperosmolar, that is 1200. Okay. Now this sodium potassium chloride co-transporter which is present here, listen carefully. Now this is the transporter which is blocked by loop diuretics. So loop diuretics act in loop of Henle. Which loop of Henle? Thick ascending loop of Henle, right? So thick ascending loop of Henle. Okay. So if you talk about the congenital aspects, these solutes, right, there is a defect in all this mechanism. If there is a defect in this mechanism, then it leads to a condition called Bartter syndrome. This is very important medicine MCQ, Bartter syndrome. Now what happens is, obviously the mechanism gets disturbed and the osmolarity of the urine also gets disturbed. Now this is all about the counter current multiplier. Then what about the counter current exchanger? This is a little bit complicated, but it's not complicated, right? You listen carefully, you can understand. What about counter current exchanger? You take loop of Henle. Now from here the osmolarity goes on increasing, 300, 600, 800, 1000. Then here it will be something like greater than 1200, that's the maximum osmolarity. Then again from here, right, it will be 800, then again 600. Wait. Wait. So this is all about interstitium. It's outside, right? This is all interstitium, and this is the loop of Henle. Now in the loop of Henle, what we observe is, wait. Just 1 minute. So this is interstitium. So in the loop of Henle, here this one at this level. This is all cortex. Now this is medulla. This is we are talking completely about medulla, right? And here you will be having collecting tubule. This is collecting tubule. Listen carefully, guys. This is a prominent MCQ that you see in INSET. Actually, I also see, frankly speaking, I don't like this topic, but still we should discuss, right? It's very important topic, right? So urine comes like this, urine goes out like this. Now what happens is, the osmolarity while entering the medulla in the loop is 300. In interstitium it will be something like 400. So it will be going on in a random state. So the osmolarity goes on increasing slowly. How? What happens? Due to reabsorption of water. There is a reabsorption of water. There is a reabsorption of water. Right? Now finally we comes to more than 1000, more than 1200, 800 and 1000, and it will be greater than 1200. This is all interstitium. This is all interstitium. Now here also you will be having more than 1200. But as the urine goes to the ascending limb, now again the osmolarity decreases. 600, then 300, then 100. Again the osmolarity decreases, but in the interstitium it resembles like this, right? So the reabsorption of water in the descending loop, the reabsorption of water leads to hypertonicity of the urine. Now while going into the ascending limb, the urine becomes hypotonic because due to reabsorption of sodium or solutes, not sodium but solutes, randomly calling solutes. What solutes? Sodium chloride. Sodium chloride. And here you also see a one small carrier. What is that carrier? Sodium potassium chloride carrier. Now this is blocked by loop diuretics. This is blocked by loop diuretics. Now if you take collecting tubule, obviously you finished what is that? Loop of Henle, then again distal convoluted tubule, and while the urine coming towards the collecting tubule and enter the collecting tubule, the hypotonic urine enters. Now slowly the tonicity of the urine increases again. 600, then it goes to 800, then again to 1000, and finally hypertonic or concentrated urine comes out. Now why the urine became hypertonic or concentrated? Because due to reabsorption of water which occurs in the collecting tubule. Now you understand or not? Yes. Now LOH finished. Finally distal convoluted tubule. Now there are two types of cells in distal convoluted tubule. Not two types of cells. So if you come to the distal convoluted tubule, which is the early part, there is a transport called sodium chloride co-transport. Now generally it is blocked by thiazides. Thiazides means hydrochlorothiazides, all this, thiazides. Now if there is a defect in this sodium chloride co-transporter, that defect causes some syndrome called Gitelman syndrome. The defect in the sodium chloride co-transporter present in the distal convoluted tubule early part. That defect is seen in so-called Gentleman syndrome. Okay. Now coming to the collecting duct. There are actually two types of cells in collecting duct. Right? Two types of cells. Now the first type is eye cells. Eye cells are also called intercalated cells. Eye cells are intercalated cells. Now what is their function? They are used for acid secretion, and mostly acidic urine. Most acidic urine and minimum pH of the urine is maintained by this intercalated cells. Now what is the minimum pH of urine? Is 4.5. Right? Now this is what is called as limiting pH. Understand? This is called as limiting pH. Now coming to the other type of cells, that is P cells. P cells are principal cells. I cells are intercalated cells. P cells are principal cells. These principal cells, they helps in potassium secretion. What they do is they decrease blood potassium and also the sodium reabsorption by increasing the serum sodium. Okay. So they increase the sodium, so they just increase the serum sodium by which channel? That is also important. By ENaC, that is epithelial sodium channel. They decrease the sodium, they just simply increase the potassium secretion, by which they decrease the blood potassium. Right? Secretion of potassium means what is happening? Secretion means the potassium is getting into the urine. The potassium is getting into the urine. So obviously the blood potassium decreases, and also they helps in sodium reabsorption. Sodium reabsorption means they are increasing the serum sodium. By which channels? By epithelial sodium channel. Now this epithelial sodium channel present in P cells of collecting tubule is blocked by very important drug. Remember please everyone, amiloride. By amiloride diuretic. Now this amiloride diuretic is the drug of choice. This amiloride diuretic is the drug of choice for Liddle's syndrome and lithium induced diabetes insipidus. Now everyone understood the see, this is what the beauty of physiology. You learn the physiology, you learn the medicine, you learn the pharma, you learn the pathology, everything. You should know the physiology, how the hell the mechanisms work, right? If you know how to perform something with your wife, then only you can make your wife to give birth to kids. If you don't know how to do, then what will you do? Simply you discuss about osmotic diuretics in the first night. Obviously, if you know how to do the If you know how to perform something with your wife, then you can make her pregnant. But if you don't know what to do in the first night, the only thing you can do with your wife is you simply discuss about this osmotic diuretics or some cardiovascular system. You just simply discuss with her. That's the only thing you can do with her during first night. Okay. Now, one more thing is, we discussed about the P cells. Now, P cells, that is principal cells. These P cells, they are actually stimulated by aldosterone. They are stimulated by aldosterone, which leads to increase in serum sodium as well as increase in serum sodium as well as decrease in serum potassium, and causes metabolic alkalosis. Why alkalosis? Because we are losing calcium and we are gaining sodium. So obviously it forms metabolic alkalosis. Now this condition is what is called Cornish syndrome. Cornish syndrome. Now, what is the drug of choice? That is important question. The drug of choice in Cornish syndrome is spironolactone. Why spironolactone? Can anyone speak? Because spironolactone is potassium sparing diuretic. Always remember, potassium sparing diuretic. Okay or not? Okay, now what is the time? We will check the time. Oh, it's 3:30. Fine, no problem. Now we will discuss something about Addison's disease. Addison's disease we will discuss in the medicine itself, right? But simply I will tell one thing. Addison's disease, I will just give you some short tips. Addison's disease, only comment I can make here is, I think most of the boys can understand. No Vimal. You know Vimal? Ajay Devgan. Vimal means Ajay Devgan. No Vimal. Only salt. Okay, fine. Some of the people, I think they don't like this things. Okay, fine, leave it off. So we'll directly go into the condition. There is a low aldosterone, low sodium, and the drug of choice is hydrocortisone. Okay, but we will discuss Addison's in detail in medicine. Okay, don't get panic. Right? Now we will discuss the collecting duct. The collecting duct is permeable for water and urea with ADH, antidiuretic hormone. Now there is actually a transporter, that is UT3. It's a urea transport 3. It makes urea enter the medulla. And what it does is increases the osmolarity, and it increases water reabsorption by a aquaporin 2, that is V2 receptor of ADH. V2 means vasopressin receptor of ADH in P cells, right? So there is a increased water reabsorption that takes place through aquaporin 2 channel, which is actually a V2 receptors, vasopressin 2 receptors, vasopressin 2 V2 receptors of antidiuretic hormone present in P cells, right? Now there is a condition called SIADH, which is there is a more production of ADH, more secretion of antidiuretic hormone, so more water reabsorption, it leads to hypertonic urine. That is 1200 milliosmoles. Why urine is becoming hypertonic? Because most of the water is being reabsorbed into the blood. So obviously the urine will become hypertonic. That is 1200 milliosmoles it became. Now, will the urine volume decreases or increases? The urine volume will be decreased because most of the water is being reabsorbed. So obviously the urine volume will be decreased. Now the same thing it happens reverse in case of diabetes insipidus. Insipidus, right? What happened? There will be less ADH. So obviously you will get less water reabsorption. There will be less water reabsorption and the urine will be at most hypotonic, very low tonicity, something like 50 to 100 milliosmoles, right? And there will be high urine volume, more urine will be excreting, high urine volume. Is something you can define it like polyuria. Polyuria, always polyuria. Okay, polyuria. Okay, now we will discuss some of the values. You may get a direct question. What is the renal blood flow? That is 1200 ml per minute. What is the total renal plasma flow? That is nearly 625 ml per minute. Now what is the glomerular filtration rate? That is nearly 125 ml per minute. What is the glomerular filtration rate? It is the amount of plasma filtered per unit. GFR is amount of plasma filtered per unit. Guys, plasma present in which component? Vascular component. Okay, remember. Again we will discuss the body fluids once again. So if you take total body weight, 60 to 70% is water, in which 2/3 is ICF. For example, he is a 60 to 70 kg body weight, then obviously total water will be 42, in which 28 liters will be ICF and 1/3 is ECF, that is 14 liters. In this 1/3 ECF, 75% is interstitial fluid, that is 10.5, and 25% is plasma, that is 3.5 liters. Okay, please remember these things. Okay, now we will discuss something about the clearance. I think it is better we block it here. Okay, the video is too lengthy, we will block it here. I will just do the next session, right? Okay, no problem, don't panic, just it will continue, that's it will continue. I will finish the session today itself, don't panic.